Dr. Carlson, thank you for answering some questions that we have that will be hopefully useful information for parents. And I was wondering if you could tell us a bit about how to recognize depression in children and adolescents.
It's my pleasure, and I have an acronym that I call DUMPS for my screening questions for depression. DUMPS is in down in the dumps. The D for DUMPS stands for a definite change in personality. Child has been, previously in a reasonable mood, now becomes depressed, dysphoric, down, and that's the first symptom. The U in DUMPS is for an undeniable drop in grades, because depression in kids and in adults has a cognitive component. People are indecisive, they can't concentrate, they are unmotivated, and that impacts their grades. Mm-hmm. The M is for morbid or suicidal ideation. Kids who are depressed are often wishing they were dead, feeling miserable. P is for pessimism, or I like to say looking at the world through poop-colored glasses. They have negative feelings about themselves. They look at the rest of the world in negative ways. They look for evidence to confirm that their lives are miserable. And the S is for somatic symptoms without a medical basis. Kids who are depressed often have headaches, stomach aches. They don't feel good. You don't feel good when you're depressed. So kids are often in the nurse's office. They may end up having lots of pediatric visits. Sometimes their parents don't like to acknowledge, or they don't recognize the feelings of depression, but sick feelings get more attention than feeling feelings. So somatic symptoms is the last major symptom.
So if a parent notices that their child's emotions and behaviors have started to change, so they seem down in the dumps, to use your acronym, when should parents start to be concerned that this isn't just a passing phase, but it might be a problem?
Well, I have a simple, my 3 Ps is my solution to those kinds of things, Carlson's 3 Ps. If a condition, whether it's depression, ADHD, mood, whatever the thing happens to be, if it's persistent, pervasive, and impairing. By persistent, it means it's lasted, in DSM terms, it has to last for more than 6 months. In Carlson terms, it has a lot to do with how impairing it is, because if the person is significantly impaired, it should, don't let it go for more than 3 or 4 weeks. So persistent, impairing, and pervasive is the other one. It should be evident in more than one setting. It doesn't necessarily have to be just home or school. If the child admits it and you would notice it, that's, more than one informant going on. So persistent, pervasive, and impairing are my ways of doing that.
Okay. So if a parent notices that their child's down in the dumps, it's impacting many aspects of their life functioning, it's lasted for a while, and it's something that there is a growing concern about, what should they do? Who should they speak with?
Well, now you're encountering our mental health system. I guess there are several ways into the mental health system. Your pediatrician may have some advice. Sometimes the provider book in your insurance company has some people that you can go to. I'm a child and adolescent psychiatrist, so it's unusual for people to hit my radar screen right off the bat, but honestly, a good diagnostic assessment is usually the most important first step to make, because you really want to find out if this is a stressor that you can alleviate the stressor and take care of the problem, or are we talking about a clinical depression, which is going to take more sophisticated managing than just attributing it to something. And one of the biggest mistakes that I've seen is people, well-meaning people, will say, oh, they're just going through a divorce, or oh, they moved to a new school, or oh, and so something is allowed to go on for a long period of time because they can find some excuse or explanation, and in fact, that's not the reason for it. So I think a good diagnostic assessment is the first step.
Okay, so one should perhaps go to their physician or seek out a psychologist or a psychiatrist or another mental health provider for a good assessment.
Yes.
And then I note that it's difficult to say exactly what treatment should be for every kid that you see, because every child presents differently. But could you give us a takeaway message for parents about how to pursue treatment, what good treatment looks like, and what can help to make them an informed consumer?
I have a sheet that I sort of print out for parents when I kind of debrief them on what kind of treatment modalities that they want to pursue. So think of a branch here. We've got somebody for whom we now maybe have had a diagnosis of a clinical depression. The first step in that thinking is how severe is it? I mean, it could be like, very severe, the kid is suicidal and he's really, really, really depressed, in which case you may even be thinking about hospitalization there. If the depression is on the milder side, then the next branch in your tree is how willing is the child able to talk about his feelings? Does he recognize feelings? Is the family supportive of that kind of intervention? Is this a family issue? In which case you're talking about more psychological interventions. Probably we've got some evidence base that says that there's two kinds of treatments that have been effective in depression: cognitive behavioral treatment and interpersonal therapy. Chit-chat therapy has no place in the treatment of depression. If there's one thing that I can go ballistic about, is the how was your day treatment, where you go to see somebody and basically all you do is chat about how your week was. That's just a waste of time and money. So you really need informed treatment, and so you need to ask your clinician who you're seeing. Usually it's a psychologist, sometimes it's a social worker. I've read about this thing called CBT, or I've read about this thing called IPT. Tell me what you're doing. I'm not sure, I mean, I can't give you lectures about this, but I think there are some informed websites that kind of tell you what the principles are. It's certainly something that I ask people about. So that's the mild depression, or if the person is wanting to go more of a talking route. People who don't like to talk, or for whom the depression may be more serious, there are a number of medications that have been used, antidepressant medications. Several of them have FDA approval, meaning that they have been studied in children and adolescents, and they've been shown to be more effective than placebo. Fluoxetine, I'm supposed to use generic names. Fluoxetine is the one that's got approval in children and adolescents. Escitalopram has got approval in adolescents. There are a couple of other medications for whom there have been positive trials, like sertraline. Probably all the serotonin reuptake inhibitors have got some efficacy. The difficulty is that there's a high placebo response rate in antidepressants in use in kids. It doesn't mean the drugs don't work, it's just that by FDA standards, you've got to be more effective than a sugar pill. But medications can be very helpful for certain kids. There's no free lunch with medications. There's no free lunch not treating the person either. But anyway, the side effects that we most get concerned with the antidepressants, physical side effects are no different really in medications than placebo. There are two psychiatric adverse events that we're most concerned about. One is increased suicidal behavior, and the other is what's called activation. And the suicidal behavior increases are very low compared to placebo, but they can occur. It's not that kids are more likely to kill themselves, but they certainly are. They may be more likely to talk about it. And so it's important to keep in close touch with your child, of course, but it's also important to keep in close touch with your physician. Activation is the other side effect, where the child may become more irritable or have more trouble sleeping, or maybe even look like they're developing manic symptoms, and the same thing is true. You got to talk to your doctor about that. Overall, the rates of improvement on antidepressants far outweigh the risks of bad effects. So overall, there's more benefit for treatment than risks. But as I say, there's no free lunch, and you always worry about the risks as well.
Mm-hmm. You've given us a lot of information about ways to treat depression, which I know is also called a mood disorder. And you treat mood disorders as well as children and adolescents who have difficulties with behavior, impulsivity, mood swings. I'm hoping we can talk about each of those, but I wanted to ask first too, one thing that's closely related to depression is anxiety. Is the way that you would treat anxiety, or the advice that you would give to parents about anxiety, similar to depression?
Overall, it's similar. That is to say, there are psychological interventions and medication interventions. The psychological interventions are more shaped to the anxiety. They're usually things that are making the child anxious, and so that the treatments that get done have to do with helping the child learn how to calm himself down, and then get gradually exposed to the things that are making him anxious and practice sort of getting on the horse after he's fallen off of it. And so the kinds of psychological interventions are different. The medications actually are very similar. I mean, they're the same medications. I can't answer for you why it is that they work differently in anxiety than they do in depression, but they seem to be, in fact, more effective in anxiety than they are in depression.
Okay. And then for other problems that children and adolescents may face, so things like attention deficit hyperactivity disorder or seeing changes in mood like bipolar disorder, what information would you want to give to parents about ADHD and bipolar disorder?
Well, let me just, you were actually reminded me of something that I think is worth mentioning. Kids with ADHD, a significant percentage of them, in fact, have some mood lability or mood problems, with a low frustration tolerance being one. When you have ADHD, you're in trouble all the time. You know, there's nothing you can do right. People are telling you to sit down, be quiet, finish your work, you know, keep your hands to yourself, look with your eyes, blah, blah, blah. You know, you're always putting your foot in it. And if you don't get that treated after a certain, and even if you do get it treated, after a certain amount of time, you can become pretty depressed and demoralized. And so one of the things that we see not uncommonly in adolescents is depression. And the question is, are these kids demoralized or are they depressed? And the question is, do you treat the ADHD first or do you treat the depression first? If the ADHD hasn't been treated, to me, I will sometimes say to the kid, what's worse for you? The ADHD symptoms, which I've now told them about, or the depressive symptoms? Sometimes the kids will say, treat the ADHD first. Sometimes they'll say, treat the depression first. If the choice is up to me and I think the problems are equal, I usually treat the ADHD first just because it's quicker to do and you get an answer more quickly than you do with the depression. Sometimes you have to do both. As far as the bipolar disorder is concerned, there's a good deal of controversy, as you may know, about the diagnosis of bipolar disorder and distinguishing it from ADHD, because children with severe ADHD and severe mood lability certainly have many symptoms that people can interpret as bipolar. They have severe outbursts and meltdowns and so forth, and some people consider that a proxy for bipolar disorder. The difference in my books is that a person with ADHD and mood lability does not present this as a new symptom. They've been that way for many years. Whereas a manic episode, which is what you confuse with severe ADHD and explosive behavior, should be an episode. It should be a distinct difference from your previous functioning. If you're not sure, in my books, I again treat the ADHD first. I try to explain to a parent, this is not an easy diagnosis and differential to make. This is not a slam dunk. I want you to kind of keep careful notes of how often your child is having outbursts and so forth. We get baseline rating scales on these things, and then we initiate a treatment and we take a look whether at home and in school you're getting an improvement in your symptoms that you're targeting. And sometimes you need to, even when you get the ADHD treated, you may need to add something else to help the mood lability. Sometimes treating the ADHD by itself is enough. With some kids, ADHD medications actually may seem to make the child's behavior worse, in which case at that point you need to go in and treat the mood and the aggressive behavior, and after that you take a look at the ADHD symptoms, and then maybe you have to go back and treat that.
It sounds like this is a really complex issue and that there's not a simple answer for it. So one thing that I'm hearing is that parents really need to work very closely with their mental health treatment provider, whether it's their psychiatrist, their psychologist, their therapist, to make sure that they're giving them frequent information about how their kids are doing and also information about whether things are changing with their kids. Is there another takeaway message for parents? There
really isn't. I think, there's an H.L. Mencken, I think it is, statement, every complex problem has a simple solution that's wrong. So I think anybody who thinks this is simple is naive. I think I get two questions from parents most frequently. Number one question is, does the child have to be on medication for the rest of his life? And my answer to that is I don't know what's going to happen to anything for the rest of anybody's life, that you treat the child as long as he's being impaired by the symptoms that he's got. The second thing that I often hear from parents, I don't hear them complaining about, but I get it circumstantially, is nobody has really sat down and debriefed them well. That often when I give them a good explanation about their ADHD, the child's ADHD, or about their mood disorder, their anxiety disorder, whatever it is, you can see the penny dropping. You can see things falling into place as they understand their child's behavior. That psychoeducational component is absolutely vital to every single condition that we've got. And it is the first step in treatment, and it is the one that often gets parents most on the same page with the practicing doctor. And that's the piece that I think they need to demand and hope to heaven that they've got a treatment provider that'll give them that.
Mm-hmm. It sounded to me like you're saying that parents really need to be an advocate at every stage of treatment for their kids. So they need to be an advocate for their children and their adolescents and recognizing if things are changing or if their child or their adolescent's having difficulty in functioning at school or at home or with the family, so that they need to be aware of that, document it. They need to be an advocate in choosing a good mental health provider for their child. And then they also need to be an advocate in helping to make sure that they understand as parents what a mental health diagnosis means and what treatment means. Am I understanding?
Yeah, you are. That's no small thing for parents to do. The most organized parents I have are the ones that come in with all of their various evaluations and report cards and stuff in a nice folder so that I can look through it and make some determinations. Unfortunately, I think people get a lot of misinformation. They're trying to advocate, but the information they get is not all the same, so I think that's kind of complicated. Unfortunately, there's lots of times when clinicians just kind of turn over treatment to the parents, so the parent's advocating and controlling treatment. I want my child on this. I want you to do that. I think there's a difference between being informed and telling somebody what to do. I certainly think you, as a parent, should be asking for explanations, and it should make sense to you every step of the way. If you're not able to get somebody to give you a reasonable explanation, take your baseball bat and glove and leave.
Mm-hmm. Well, thank you so much for your time and for answering questions. I think this is going to be really helpful for parents to hear. Any other information that you want to give to parents?
I think, as frustrating as it is, I think it's important to understand that we've made a lot of strides in understanding diagnosis and treatment over the last 20 or 30 years in kids. There's a lot of misinformation out there. There's a lot of positive things that we can say about what we know about mental health and treatment in kids. I also think there's a lot of things that we don't know. And so I also think that there's a certain amount of humility that I, as a practitioner, have to have, and that I think it's important that we work with parents and with the kids to do the best we can with what we got.
I think an important point you just made that I want to ask you about is you said we've made a lot of strides over the past few decades in understanding and treating children's mental health problems. So can parents safely have hope that their kids can get better?
Well, you know, I think one of the things that I have learned as a clinician all these years is that development is a wonderful thing. A lot of times what we're doing is making things better until development takes over and things kind of improve. Many of the conditions that we treat are fairly chronic. I wish I could say we had a magic bullet that was going to cure everything. We don't have magic bullets. Research is, I hope, working on magic bullets, but we don't have them yet. But that's true for most of medicine. We don't have magic bullets for high blood pressure or diabetes or strokes or, you know, any other serious medical conditions, but we certainly have things that can make it better for people who've got those conditions to live with them. And as I say, with kids, some of the conditions they have are developmental, and they get better as the child's brain grows and some of those things take place. And so our job is to try to get the child in the best place he can be or she can be, so that they are greeting adulthood with as many opportunities as they can have.
Great. Thank you very much.
Thank you.